Hi everyone, and welcome to this video lecture on the neuroscience of mental disorders. I think we had a pretty good class last week, enjoyable class reviewing neurofeedback and getting that demonstration, and I wanted to make sure that we went over the content as well from this past week's reading, so that we can we can explore this topic in a bit more depth, because I think some of the pieces we're going to go through are pretty important to your understanding. Some of the key terms we're going to review today include the default mode network. We've already learned a bit about that. We'll be exploring that in a bit more depth today relative to mental disorders. The frontoparietal network, and some different hypotheses for mental disorders, one for autism, known as the alternative poly-adenylation hypothesis, the monoamine hypothesis for depression, neuroplastic hypothesis for depression, and the glutamate hypothesis for depression. We'll also talk about seizures and traumatic brain injury and contusions. Let's start out with the default mode network. There are several brain regions that are implicated in this network that are involved. The first is the medial prefrontal cortex. The second is the posterior cingulate cortex. You may remember that as being subcortical. It is not quite at the depth of the limbic system, but close to it. It's certainly below the frontal lobes, for example. The inferior parietal lobe and the lateral temporal cortex, and we're going to talk about the parietal and temporal lobes in just a moment. You may remember that there are four lobes of the brain: the frontal, occipital, parietal, and temporal. And then the hippocampal formation, which of course is in the limbic area. Now, let me talk a little bit about the default mode network and what it's about, and then we'll look at the anatomy of the default mode network in the next slide. The default mode network is essentially about when we find ourselves just thinking without any explicit goal of thinking in mind. I'll give you two clear examples of this. Let's say that you are driving back home or getting a public transportation home from a class that you've had, or from a job, from your work. It's not uncommon for you to be just thinking about the events of that day and processing them, and to suddenly catch yourself thinking about them. So in other words, you are pre-consciously, without conscious awareness, processing the events of that day. Okay? There's another example, which is the creativity example. Sometimes you'll be thinking about the events of that day, or maybe it's a topic like a paper you're working on, or maybe it's a client you're working with, and suddenly you'll have this burst of insight, this kind of awareness, or other idea, creative idea of what to do or what to write. And that comes out of some of the processing that's happening around this specific topic. And that all happens in the default mode network. So in other words, to put it shortly, the default mode network is very important to the processing of experience, very important to developing self-awareness and self-insight. And when it's impaired, it leads to problems with self-awareness, self-insight, lack of creativity, and can even lead to problems with just being unable to process events that have happened, and so difficulties with memory. Okay? If you're interested, there's a YouTube clip that's worth watching that further describes the default mode network. There's a link at the bottom of the screen for that. You could basically copy that and put it into a web browser and watch the video. It's a couple of minutes long and is helpful for understanding what's involved in the default mode network. Here's the anatomy of it. Let's talk about the anatomy, and then we'll talk about its role in the deficits of ADHD, autism, and even schizophrenia and bipolar disorder. So you'll see on the bottom left the parts of the brain that we've gone over before in terms of the areas of the prefrontal cortex, or I should say frontal cortex. So you have the dorsolateral there, you see that, ventrolateral, ventral medial, dorsal medial. The medial means midline, so that's the middle of the brain, the middle of the head. And when it's prefrontal cortex, it's towards the front of the head, just at the midline, okay? You also see there peeking out the ACC, or anterior cingulate cortex. Remember that The posterior is just slightly behind the ACC, so it's just beneath the top of the brain, and is still towards the top, though, the posterior cingulate cortex. So in addition to that, the areas of the brain that are impacted by the default mode network are not just the frontal lobe, but also towards the back, the parietal and temporal lobes. You may remember that the temporal lobe has to do with auditory perception, also language comprehension, and then the parietal lobe has to do with somatic and sensory awareness. Now you may be wondering, well, what does that have to do with this self-reflective thought? Well, oftentimes when we are processing sound, speech, things that we've heard, the temporal lobes are activated. And in addition, if we're processing sensory experiences we've had, the parietal lobes are impacted. Okay, so all this to say that there are very different brain regions that are tied to the default mode network. And when we engage in things like mindfulness or yoga practice, we tend to engage those areas, the prefrontal area, but also the parietal and temporal areas of the brain. Okay. Now, what happens when these things have deficits, when the default mode network is underactivated or overactivated? In ADHD, you see there being a difficulty with mind wandering, with the ability to control a thought. It's difficult for the person to pay attention. And so in the default mode network, again, if you have too much activation of it, even at periods of time where you should be more focused, it can be problematic. And so that lack of control over the default mode network you tend to see in ADHD. Now, what's interesting is that the underactivation of the prefrontal cortex, which is involved in the default mode network, that could be normalized by medication, particularly the dorsolateral prefrontal cortex. And so you tend to see with people who have ADHD who are taking stimulant medication that they normalize parts of the default mode network. With autism, what you tend to see is a difficulty with self-referential thought, or being aware of oneself, being aware of one's thoughts and feelings. And again, that's how the default mode network has a large role. And then schizophrenia, it's interesting, not only do you see that self-referential piece missing sometimes with people with schizophrenia, they have difficulty, for example, with being aware of how they're behaving and how that impacts others. They also can have hallucinations related to auditory or somatic issues. And when they do have hallucinations, often it's because of this difficulty with having these overactive parts of the brain, for example, auditory perception, and underactivated parts of the prefrontal cortex, and this difficulty, therefore, with regulating experience and regulating thoughts. So if you read the research literature, it may not always use the term default mode network in these disorders, but it will use very similar terms like frontal parietal network. And essentially, it's talking about default mode network, that this is this system, if you will, is very impacted in quite significant mental disorders. And so how do we address that? How do we work through that? One of the things we can do is use neurofeedback. That could be very helpful, particularly for ADHD, where it has an FDA indication. Unfortunately, mindfulness, while it can be very useful for most people in activating the default mode network, it tends to be a bit problematic for people who have these more, I would say, neurodevelopmental or neurocognitive issues, such as ADHD, autism, and schizophrenia. These are more brain-based disorders. And a person with ADHD is going to have difficulty with reining in thought, with sitting still. A person with autism is going to have difficulty, and with schizophrenia too, of contacting interoceptive awareness and their own internal state. So it makes mindfulness a challenge. Not that you can't do it, but it would be a bit of a challenge for a person to do. So you have to find other ways of activating the default mode network, and neurofeedback is probably one of the best ways of doing it. Related to this, related to the default mode network, I should mention what happens in persons with schizophrenia. They've done studies with a smaller amount of clients or patients, granted. that have shown unfortunate decline in gray matter volume in regions of the default mode network. Now, you may remember that gray matter has to do with unmyelinated axons. Remember, when a neuron gets myelinated, messages are sent more quickly because there's better ability to transmit electrical charge. Now, but still, what happens is as we age, more and more gray matter gets transferred to white matter through myelination. Now, during critical periods, the age of 13 to 18, they imaged persons with schizophrenia over a 5-year period. And unfortunately, what they found was, if you look at the diagram there, the red regions had the greatest loss of gray matter. And those regions were especially associated with the parietal and anterior temporal cortex. So in other words, those lobes of the brain, the parietal and temporal lobe, which we've already substantiated have a major role in default mode network, have a reduction in gray matter volume, making it even more difficult for persons with schizophrenia to activate the default mode network in a balanced way, right? And so there is somewhat of a biological predisposition towards an imbalanced default mode network in schizophrenia. We also see this imbalance in ADHD, and it's very interesting because I should begin by saying not all adolescents with ADHD will go on to have ADHD in adulthood. It's only about a 50% rate of persisting ADHD into adulthood. 50% of people do not have ADHD in adulthood if they have it in adolescence. So what's going on that for some people they are able to overcome ADHD and for some people they're not? Well, there's I think emerging evidence that it has to do with the connections in the brain between the posterior cingulate cortex and the regions of the medial prefrontal cortex, which we've already substantiated have a role in the default mode network. And so what you tend to find, if you look closely at the diagram for A rather than for B, if you look at the control and remitting ADHD, you'll see there's activation towards the frontal part of the brain as well as the PCC part of the brain. Whereas if you look at for persisting ADHD, there's just activation in the PCC, not necessarily for the frontal part of the brain. Okay. Now that's problematic because basically, again, you're having this lack of linkage, right, from the PCC to the medial prefrontal cortex, make it difficult for a person to make sense of, to control, to have executive functioning over components related to impulse control, memory, and other functions of the PCC. Emotionality, emotional regulation, those are things that the PCC is responsible for, and not so much the executive control piece. And so for persons who have persisting ADHD, they don't develop the ability to rein in those emotions, those impulses. There are some, I would say, chronic or persisting or kind of, what's the other word I want? Residual effects of ADHD that can be present for both people with remitting and persisting ADHD. And that is the negative functional connectivity between the medial prefrontal cortex and dorsolateral prefrontal cortex has been found for only people who have never been diagnosed for ADHD. For people who've been diagnosed with ADHD, they tend to have that problem persisting. And you see that when you look at, again, A rather than B in the diagram. For the control group, you see there are those two blue dots that are not seen for the other two groups. It has to do with the ability for different parts of the prefrontal cortex to be, again, connected, to be in contact with each other. And therefore, issues like executive function and decision making can be somewhat impaired even into adulthood. And that's why you find when working with people with ADHD who've had it in childhood, while they can certainly make major gains, there do tend to be some residual effects. Okay, I'm going to move on now to talk about autism a little bit. I want to talk first about models for conceptualizing autism. There are a lot of different models. I'm going to go through some of these today. The first is the genetic model. There are certain genes that are linked to autism, though I'll also mention here that these genes, none of them has like a 100% prediction rate, and often we're talking about multiple genes involved, not just one gene. We have frontal parietal deficits that we just talked about with the default mode network, because remember, frontoparietal is often used as a synonym for default mode network in the research. GABA imbalance, remember GABA, that is basically an inhibitory neurotransmitter, and you tend to find, therefore, in people who have autism, difficulties with regulating anxiety. And then you have issues with oxytocin and social bonding that are proposed, though I will say the evidence here is a bit mixed. For example, when they've done studies with people with autism, children especially, and they have given them oxytocin nasal sprays, they don't necessarily find consistently that better bonding occurs. So I don't know, it's a bit mixed, but certainly there's a theory that because oxytocin is a bonding hormone, people with autism tend to have difficulty with bonding and social relationships, with empathy and perspective taking. Could it be that there's a linkage there? There's also a theory of metabolic dysfunction and impaired microbiota gut-brain axis. And that certainly is an interesting one for us, because so many people with autism have, especially I would say lower functioning forms of autism, can have a very restricted diet, and we wonder about the role of the metabolism there in the development of autism, and also the perpetuation of certain symptoms because of this restricted diet, among other things. Before I get to, there's yet another theory of autism that I'm going to cover. I wanted to at least briefly mention, since I had talked a little bit about bonding, one of the major issues that is consistently found in the research for people who have autism is a difficulty with recall of faces. They've done comparisons between people who have autism and typically developing children and adults, and have found that in general, people with autism tend to have a grand difficulty with recalling faces compared to people in typically developing populations. And what that means, of course, is quite profound, because there's a large element of affective and social neuroscience that talks about the role of facial recognition in social relationships. That if we can't recognize faces, if we can't understand the emotions that people have, and we don't have some kind of way of gauging which people are familiar to us and which people aren't, that can have a major impact on our social life. It can create all kinds of difficulties. And so the recall of faces is quite important to our social functioning, and is quite impaired for people with autism. There's also another alternative hypothesis for autism that I should touch on, known as the alternative poly-adenylation hypothesis. And it essentially has to do with calcium signaling. Now, let me explain. You may recall when we talked about neurotransmission that in order for an electrical charge to be sent through a neuron to another neuron, there was basically the signaling and reception of calcium ions into a cell, and those ions have basically what's involved in creating the electrical charge that then sends through the next cell. Now, with autism, there is an over-transportation of calcium, too much calcium. And what happens with high concentration of calcium is that the neuron doesn't function properly. And that leads to problems globally with neurotransmission, with all different types of neurotransmission. And so there's a bit of a concern there about how, or at least there's a theory that says part of the problem here is that in the gray matter of the brain, in unmyelinated axons, there's too much calcium transport, and that's part of what causes autism, or is linked to autism. Okay, now that I've talked about different neuroscience theories for autism, you of course read an article this week about how to work with families who have autism spectrum disorder. While the neuroscience in that article wasn't wasn't there. It wasn't really a neuroscience related article formally. I think I at least wanted to give you information about how to work with parents and families, because many of you will be working with clients who have autism in the future. And it's very helpful to get a bit of guidance about how to effectively work with those families. So here are some tips I'm going to give to you. First, active listening is more effective than problem solving because many of the child's issues cannot be easily resolved by the parent. I'll give you an example. If the child is having difficulty with sleep and is up most of the night, there aren't necessarily easy solutions to that. Not even medication is always an easy solution. And so instead of constantly problem solving with the parent, it could be actually more powerful and empowering to the parent just to feel heard and to feel listened to, and to know that some of their problems aren't solvable easily. That can be just as powerful as an intervention for the parent. Second, positive reframing is very useful to help parents display love and affection towards their child. It can be very wearing and draining to be raising a child with autism, particularly lower functioning forms of autism. And the parent may be getting burned out, they may be getting tired and frustrated with their child. And so helping them to be able to take a more loving approach, more patient approach with their child will have results in terms of the child's own behavior, based on elementary systems theory. So if we're able to help the parents to kind of reframe how they interact with the child, it can be quite powerful. If we're working with a family who have a child with autism, oftentimes there are ambiguous loss pieces that are there quite prominently that really need to be worked through. I'll give you a couple of clinical examples that I've had in the past. I've had parents in the past who have put their children through really extreme forms of treatment for autism in the constant hope that their child is going to get cured. They've done things like chelation treatment, which involves heavy metals. They've done all kinds of light treatments. They've made them wear special sunglasses. There's all kinds of different things that parents will do to try to help their child. And that's all well and good if the intervention is A, evidence-based, and B, it doesn't come from a place of just desperately clinging on to the idea that there is a cure out there for the child and that you'll finally be able to wrestle them free of this diagnosis and that they'll become a typically developing child. That is not going to be the case for the 99% of children diagnosed with autism. They are going to have autism as a lifetime diagnosis. And so you have to help the family to acknowledge that and sit with that and work with that, and to be more compassionate to their child and to themselves. Because if you can't accept that loss, it can lead to the family pushing too hard for change when it's not really going to occur, and getting frustrated in the process and making the child react a certain way. Like the child could become quite resistant in the process and even aggressive. I'll also add that ambiguous loss is a very understandable phenomenon. Let me explain why. A child with autism does not have an obvious physical disability. They don't have a disfigurement, they aren't in a wheelchair, and yet they have a disability. And the people around them, therefore, might not know that they have a disability, particularly if they have high-functioning autism. And to the family themselves, they may come across at times as being typically developing and other times not. Or maybe there's some areas of their life that they're making major progress on and the others they aren't. And that can create false hope, right? False hope that eventually we'll find a cure for this child. Eventually they'll be able to break free of what they've got going on. And that's what perpetuates the cycle of ambiguous loss, that you have this hope that comes, and then you have the two steps back, and it just perpetuates and perpetuates and keeps the family on the hook for just constantly hoping the child is going to change. Next, I'm going to talk to you about addressing family dynamic issues, especially in relationship to the interaction with siblings. Whenever a family is helping to integrate and to care for a child with a disability, they have to be very thoughtful about how they're interacting with the other members of the family. It's very possible for the child who has a disability to have needs that greatly outweigh the needs of the other siblings, and they have to attend more to the child with a disability. But then, of course, the siblings are going to respond to that a certain way. They may become resentful. They may become caregivers themselves to the child with a disability. And there has to be attention given to that and to make sure that the siblings get their own needs met. In addition, of course, the child who has a disability could be aggressive, or could have a negative interaction with the siblings that may need to get processed, and or the siblings may be aggressive to them. So that can all create family dynamic issues. And it's complicated because using systems theory, and I talk about this in the article, if the parent just spends more time with one of the siblings, and the child with a disability notices this, then the child with the disability could become more aggressive towards the sibling, and that creates more problems, and therefore the attention shifts even more towards the child with autism once again. And so you have to be very thoughtful about those interactions, and often the family will need some coaching to change some of those dynamic issues. Next, consider organizing a support group. Support groups can be very helpful for parents of children with autism and other developmental disabilities, because oftentimes there is no one centralized way of getting information about the services that are out there and what's helpful. And so parents will often share their experiences of getting certain services or things that they've done that were useful. And that could be very, very helpful to a family to get that kind of insider information about what works within their community specifically. Some parents will need help to self-advocate for services, particularly services within the school system. For example, they may not know about the process of eligibility and receiving special education services. Navigating complex and separate systems. As I mentioned, it's very common for services not to be centralized, and for a parent to have to take their child to a family physician, to a behavior specialist like an ABA therapist, to take their child to occupational or physical or speech therapy, to take their child to maybe even therapy itself, psychotherapy. All these different appointments that they have to take their child to. It can be exhausting for a parent. And so if you can help them somehow navigate those systems and somewhat find more centralized services, that's going to be very helpful to the family. And in addition to that, there may be other professionals involved in the client's care, and it's very important for everyone to be on the same page. For example, if you're working with the client in an individual therapy session, or you're in the schools as a school counselor or a school-based therapist, you would want to interact with the in-home therapist to make sure there's consistency in what you're telling and working with both the child and the family on. Okay, we've talked a lot about autism. Let's move on. I'm going to talk next about depression. Now, depression is super interesting. 10 years ago, there used to be one predominant theory, neuroscience theory for depression, that everyone bought into, and there was rarely any dissension or question about it. It was known as the monoamine hypothesis, and it went something like this, and probably most of you are familiar, that depression is fundamentally a problem of under-transmission, lack of transmission of serotonin or norepinephrine or dopamine or some kind of mix of those, and that if you take medication which will boost those neurotransmitters and boost the neurotransmission of them, that you will resolve depression. Now, that messaging has supported antidepressant use substantially, because of course antidepressants increase the neurotransmission of serotonin, norepinephrine, dopamine, and therefore if a client's depressed, you give them this medication, it's going to resolve the issue. Well, we now know depression to be much more complex than that. And I'm going to talk about some of the other theories for depression that will change the way I think that you view depression, especially the neurobiological basis of depression. And if you haven't read the article that I've posted, it's very much worth your time to read through it, because there's so much more information we have now about depression than we did even 5 years ago. All right, first I'm going to talk about the neuroplasticity theory. This is sometimes called the diathesis stress epigenetic or inflammatory theory of depression. It goes something like this. It's stress related. That you have a person who experiences early adverse experiences in childhood. It could be related to caregivers, it could be bullying, it could be something within their environment. And that stress triggers a host of effects related to cortisol production and adrenaline production that then leads eventually excuse me, to atrophy in the certain areas of the brain, such as the hippocampus. It leads to other deficits in terms of neurotransmission and the lack of neurogenesis or birth of new neurons. It can cause inflammatory problems because of stress that lead to problems with the microbiota gut-brain axis and the enteric nervous system. And so all of this plays a role, therefore, in depression, because essentially early life experiences have a large impact on depression. Okay? The glutamate theory is somewhat related to this. And let me explain the glutamate theory. You're probably very familiar. There is a neurotransmitter called glutamate. Now, GABA, which you're familiar with, is the major inhibitory neurotransmitter in the nervous system. Glutamate is the major excitatory neurotransmitter. It's the one that creates a lot of neural growth. It's related to brain-derived neurotropic factor and how new neurons and new synapses are developed. And so part of the problem with depression now has been hypothesized to be a problem in glutamate, that there's too little glutamate or too little birth of new neurons, and that's why you see these reductions in hippocampal volume, reductions in certain gray matter in persons who have depression. And so if you're able to increase glutamate somehow, you're able to jumpstart the birth of new neurons that can then lead to less depression. There's a couple of biological bases of these that are well known. One of them is the recent testing of ketamine. Actually, the product that came on the market is called S-ketamine, which is known to enhance glutamate through the NMDA and AMPA receptors. And essentially, when you enhance glutamate, again, you're creating the birth of new neurons, and that's leading to a reduction in depression. So depression, therefore, is associated with the long-term depression with LTD, with this kind of reduction in gray matter volume and the development of new neurons. There are other, of course, substantiations to this. I'm trying to think of what the disorder is. It's not, what is it called? I'm going to totally forget the name of the disease, but maybe it'll come to me. There's a disease that involves basically the slow and steady reduction of nerve cells, the death of nerve cells. And when that happens, you tend to see people basically develop depressive symptoms. And antidepressants are often used to help slow the reduction of those neurons, slow the decline, if you will. And that leads to less depression. And so there was some kind of fundamental understanding of this, and it's I almost had it. I can't remember the disease that's involved. If it comes back to me, I'll share it with you. It'll probably come towards the end of the presentation. Anyway, so the other thing that I'll say that's important here is that so therefore I just mentioned antidepressants. Antidepressants are now thought to work not only through increasing serotonin, but also to basically jumpstart the production of new neurons and synapses through its relationship with glutamate and brain-derived neurotropic factor, which is super interesting. It changes the way we think about antidepressant medication. And of course, other lifestyle interventions that also are known to facilitate BDNF, which we've talked about in prior weeks, such as appropriate sleep, appropriate exercise. Those interventions are now seen as even more important in the treatment of depression. And in fact, there are more and more articles coming out about the role of aerobic exercise in reducing depression. There are structural and functional abnormalities that are well known to be associated with depression. One of them is TBI. You're probably very familiar with that. There are also medical conditions that are known to be hypothesized to be linked to depression. Hypothyroidism, which, by the way, isn't as clearly linked as you might think. There's inconsistent evidence about the role of low thyroid in depression, which is interesting. And vitamin D, which has actually more stronger evidence for its role in depression. And I still can't think of that disorder that's associated with reduction of nerve cells. I'm sure it'll come to me at some point. Okay, I'm going to say one other thing about glutamate. We mentioned NMDA and AMPA-R as receptors for glutamate. It's important here, or at least is related to that. It's related to glutamate. You'll notice in this study, there's a very interesting study that came out like 20 years ago now on mice and what happened if you modified NMDA receptors. The mice on the left have a normal number of receptors, and the mice on the right have been genetically altered to express fewer NMDA receptors. They took photographs 30 minutes apart over 2 hours, and what they found was the mice on the left, if you look at them closely, they have a pretty strong socialization. They hang out with each other, they remain close to each other, and if you look at the mice on the right-hand side, they're further apart. And therefore, there's a theory out there that somehow depression related to NMDA results in avoidance of social contact, which would explain the withdrawal aspect of depression. There's not enough evidence for it, but it's a very interesting theory. Okay, I'm going to move into talking about seizures, a totally different direction. I've talked about the neuroscience of several mental disorders now. We've talked about ADHD, we've talked about schizophrenia, we've talked about autism, we've talked about depression. Next, we're going to move to seizures. It's important for me to talk through seizures because you probably won't cover this in as much detail in your psychopathology course. And seizures are quite common, and clients will be struggling with seizures that you'll be working with. So what are seizures? Well, let's define them first and understand their frequency. Seizures are essentially about excessive electrical activity known as hyperexcited neurotransmission. That's basically too much neurotransmission, too much electrical activity. About 8 to 10% of people will experience a seizure during their lifetime. There's about a 35 to 50% likelihood of recurrence after a single episode and 75% after the second. Psychosis occurs in 6 to 10% of people following a seizure. And of course, is something we would want to pay attention to as mental health professionals. Now, epilepsy is a related but different term to seizures. Epilepsy is about recurrent seizures. In the same way that Tourette's is about a specific type of tic disorder, epilepsy is a specific type of seizure disorder. In epilepsy, the seizures are typically unprovoked, meaning they're not caused by an event such as high fever. Here are the provoking events for a seizure that can happen among people who do not have epilepsy, or who have kind of random seizures, or who even, frankly, can have epilepsy and then have provoked seizures. One is fever. We know that body temperature above 107 is a major risk factor for a seizure. Concussions, alcohol withdrawal, you're probably very familiar with delirium tremens, dehydration, low blood sugar or salt, sleep deprivation, if you have several days of no sleep, like really severe sleep deprivation, brain infection and tumors, electroconvulsive therapy, which of course aims to give clients micro seizures in the goal of reducing depression. And then stress. Stress is known, particularly for people with epilepsy, to be a major risk factor for seizures. There are different types of seizures. There are 3 types. Tonic-clonic, which is uncontrollable shaking and loss of consciousness. Focal, uncontrollable shaking without loss of consciousness, and it can also fluctuate. You can be in and out of consciousness with focal, or at least have an impaired consciousness, but maybe not totally unconscious. Absence, seizures, which are subtle momentary loss of awareness, but the person does not have uncontrollable shaking. 60% of seizures are convulsive with the shaking, so that's tonic, clonic, or focal. 40% or so are absent seizures. The average duration for a seizure is about or less than 2 minutes for convulsive seizures, and very short, about 10 seconds for absent seizures. So it's very rare you'd have someone who would be in a trance for like minutes at a time if they're having an absent seizure. Typically, it doesn't last as long. It becomes a medical emergency, particularly with convulsive seizures, at around the 5-minute mark if someone is having a significant seizure. So it's something that you certainly want to be concerned about medically if a person's having a seizure, and of course it's very unpleasant to be a witness to it. This is what happens on an EEG when a person has a seizure. You see there the hyperactivity, right, of electrical activity there. And that basically is what happens with the seizure. There's too much electrical activity. Okay, we've talked a bit about seizures. Now we're going to move into traumatic brain injury. There are different forms of head contact, I should say. We're not even talking about head injury yet or head trauma. Contusions can happen, which are brain bruises. Some of these will resolve and without much issue. Others will be more problematic. There's also a major difference between head trauma and brain injury. Well, a slight difference. Remember, you can have open and closed head injuries or head trauma. You can also have chronic traumatic encephalopathy, which is different than a traumatic brain injury, in that a traumatic brain injury tends to be one in which you tend to have lesions, or you tend to have a significant area of the brain that has a large loss of nerve cells all of a sudden. Whereas a head trauma does not necessarily have to involve that, neither does chronic traumatic encephalopathy or CTE. Now, I'll mention one piece that's interesting from recent research, which is we used to think that that the brain was just floating around in the skull. Well, that's not really the case. The brain has attachments to the skull, and that means that minor collisions do not necessarily result in injury. And I've got to tell you, as a parent, that is a breath of fresh air. That is welcome news, because I'm used to coming home and watching my children basically, jettison themselves from the couch and land on their head. I'm just joking, but they certainly get into quite a lot of contact, and so you get worried. Oh my goodness, are they going to develop head injuries from this? And the answer is typically no. That you would need to have a really substantial collision and impact to develop a contusion, head trauma, brain injury. Here are the types of traumatic brain injury. You have direct impact injury, which is, for example, a strong blow to the frontal cortex. You have acceleration-deceleration injury, which is where you're going incredibly fast, usually in a motor vehicle, for example, that all of a sudden there's a dramatic stop. And then therefore the brain, even though it has contact, has connections to the skull, the whiplash is kind of significant enough that the brain will get kind of hit from one side to the other. And then you have shockwave injury. And shockwave can happen usually for people in the military around like a blast, for example, a shockwave from a blast. And that can create all kinds of issues, as you see there. This is an example of that kind of counterblow I was talking about, that the brain will move from the left to the right-hand side, and that counterblow is what causes the injury. This is another example of the counterblow that I talked about prior. You see that the brain moves from one side to the other, and it's that kind of opposite strike to the other side of the head that causes the injury. And again, you'd have to have a quite substantial whiplash injury, contact injury for that to happen. What happens in brain injury is interesting, and I'm going to talk about that in the next several slides. You see there a normal brain, and you see in a brain injury, there is widespread cerebral swelling, okay? And that swelling can, if untreated and undiagnosed, lead to significant issues over time, particularly with atrophy in certain areas of the brain. You can also have hemorrhage, of course. This is a major concern. So you see here different forms of hemorrhage at different sites. Have to do with the contact from the brain to the skull. You can have hemorrhages that happen within the brain, deep within the brain, or hemorrhages that happen on the outside of the brain, the cortex. Some hemorrhages, by the way, I would say, are basically a bruising that can be stopped, and other hemorrhages create significant brain bleed, which is very problematic, and that's where a person would have really significant symptoms and would need to be taken to a hospital immediately. Here are some examples of types of TBI. You see there are contusion types and hematoma types, diffuse swelling types, and different types of TBI. This is a very helpful graphic, the next one, that describes the progression of TBI. On the top left, you have 2 years pre-injury, and you see there where you see the arrow that there's swelling there. Oh, sorry, that there's kind of a normal amount of ventricle. There isn't an enlarged ventricle in the middle of the brain. Then you have date of the injury, which is the top middle, and you see that there appears to be a lot of swelling there in the brain. Then 1 day post-injury, you already see, even 1 day post-injury, that there is now an enlargement of the ventricle at the center part of the brain. And 7 days post-injury, 16 weeks post-injury, and then 2 years post-injury, those ventricles continue to widen. And that's obviously a concern with TBI, that the person will actually get worse over time rather than will recover. And there's interesting conflicting data, and it really depends on the injury, about whether or not a person gets better over time with a TBI and can functionally recover, or whether they get worse. And it does depend on the person. Now, I'm going to talk next about CTE. You're probably quite familiar with this from the American football studies that are coming out. CTE is associated with increased tau tangles, and you see those in the diagram there, though not amyloid plaques. Now, this is an important finding. This is a very recent finding. Actually, it just came out of BU, believe it or not. And they're using this to identify CTE in the living before they're having to do these what's the term I want? Post-mortem brain examinations. So why is this hypothesized to be a marker of identifying CTE in the living? Well, it helps to differentiate people who have CTE from having Alzheimer's disease, which of course have both tau tangles and amyloid plaques typically. So it's just the tangles with CTE, and that's what we're interested in. Now, the next graphic I'm going to show you is pretty gruesome, but it's a helpful one to view when understanding the role of CTE in brain atrophy. I'm going to show you the brain of Aaron Hernandez, who of course was the New England Patriots football player who committed a murder and was sent to jail and died in jail. And then his brain was analyzed, and they found quite significant atrophy. On the left-hand side, you see a normal 27-year-old. That's how old Hernandez was when he died. And on the right-hand side, you see Aaron Hernandez's brain. This is his actual brain that was donated. This was a brain that was analyzed by Anne McKee and other researchers at BU. And as you can see, they found significant ventricular enlargement. And so, if you look just in general at what his brain looks like relative to a normal 27-year-old, there's a lot of atrophy there. And that's really a major issue, because we can essentially say that Aaron Hernandez had a quite impaired ability to regulate emotion, make decisions. His brain was not the same as a normal 27-year-old. And that's part of the concern about people who play contact sports, is this that the brain is essentially getting these recurrent micro injuries, and that over time it leads to tau tangles and leads to symptoms that frankly look more like Alzheimer's, because of course this is the kind of brain you would see from someone who had Alzheimer's. It's not, fortunately, without hope. It is very possible for someone who has a brain injury to some degree recover from that. What happens is that during the first few hours of a brain injury, the brain cells are damaged, some are permanently lost, and can be a sudden loss of functionality. But over time, the brain is plastic, right? And so new synaptic and connections are built, new neurons are built, and so the brain is sometimes able to recover. What often helps is using therapy, and by here I'm talking about different forms of rehabilitation therapy that help a person to recover functionality in the brain. So if a person engages in restorative therapy early in the treatment process, you notice here we're talking days after. You can't wait months after it's too late. Then a person starts to make recovery. So in other words, if you have a client that you know has sustained a brain injury, then there's clear evidence for it, they've had lab tests, they need to start treatment ASAP. And oftentimes when people have had significant motor vehicle accidents and they end up in the hospital, they will start therapy literally the next day. They'll start it very, very quickly, because we know that the earlier you start therapy, the more likely it is that you're going to make major progress and recover some functionality. Okay, I think we've just about covered everything I wanted to cover today. We've covered a lot, talked about the neuroscience of mental disorders. I hope that was helpful to you. I did just remember that if you were watching the whole way through and you're like, oh, what's the diagnosis he's talking about? It was Huntington's. Huntington's disease is associated with the loss of neurons over time. And you may remember the case of Dr. Gilmer and Mr. Hyde, which was a case of Huntington's, and how antidepressants were useful in that process of helping him to not have as much loss and neuronal loss, and he said he functioned a lot better on antidepressants. Anyway, I digress. I hope this was a helpful lecture. I'll see you next week in class, and we'll dig into neuroscience-informed CBT. I'll see you all then.